Welcome to another EduMed video, and in this video on airway pressure release ventilation we'll be going through how to set the pressure high or the PHigh. We'll go through a little bit about what APRV is, but I'd really recommend going through the first few videos in this series where we go through in a lot of detail about what APRV is and the basics of how to set it up. And then we'll focus specifically on the PHigh itself. And we'll look at how you actually set it when you first start a patient on APRV, and then how to adjust it once a patient is established on APRV, depending upon their resultant blood gases. Finally, we'll talk a little bit about the things that you should be a little worried about or think about when starting a patient on APRV and setting the PHigh itself. Now, suffice to say that APRV is an advanced form of ventilation. If you're new to ventilation or you want a refresher, I'd really highly recommend you go through the videos that I've done on the basics of ventilation, which talk a little bit about the different types of ventilation and what we're trying to achieve with ventilation itself. Only through looking at those videos will you start to understand a bit about what we're doing with APRV and why changing certain parameters will have certain effects on the patient's partial pressure of oxygen and carbon dioxide. This picture is the one picture that I want you to always bear in mind when managing a patient who's hypoxic or hypercapnic. It explains everything that we need to do for a patient in order to maximize and optimize their ventilation and oxygenation. The first thing to think about is having the alveolus open. The longer the alveolus is open for, the more oxygen diffusion there will be into the bloodstream. I keep saying it, but ventilation and oxygenation are essentially not clever processes. They don't care whether you're in inspiration or expiration. As long as that alveolus is full of gas, and that gas has a higher concentration of oxygen in it than the blood flowing through, you will constantly get oxygenation of blood. And so that's what APRV is really trying to do, is to maximize the amount of time that the lungs are full of gas, and therefore you're maximizing the time for oxygenation. The way to think of APRV is essentially extreme CPAP. CPAP, or continuous positive airway pressure, is where you're basically just blowing the lungs full of air with a continuous pressure, and that just opens up all of the alveoli that are possible to be recruited. The way to think about this is if you're driving down the motorway in a car, you put down the window and you stick your head out the window. That continuous rush of air that you get, that expands out the lungs and therefore opens up those alveoli that are collapsed due to the weight of the mediastinal tissues, the chest wall pressing down on the lungs, and the abdominal contents being pushed up through the diaphragm onto the bases of the lungs. So you're basically recruiting up all those unused bits of lung and therefore increasing the efficiency of oxygenation. And that's exactly what CPAP is. And that's what APRV aims to do, is just to maximize the amount of time that you can keep the lungs open for, as compared to conventional ventilation, where you open up the lungs for a short period and then you release that gas to then allow exhalation. There are only 4 things that you can change to manage a patient with their oxygenation. So if someone's hypoxic, the only things you can really do are to increase the amount of oxygen that they're breathing in, and that's generally done by changing the fractional inspired oxygen concentration, maximizing the amount of time that the alveolus is open for and not allowing it to collapse down, and that's really what APRV aims to do. Improving alveolar blood flow. This is something that people always forget about, and another reason why I always show that picture of the alveolus with the capillary at the start of any ventilation lecture. Ventilation is as much about the blood flow through to the areas of lung that are getting gas exchange as it is about the gas coming in and out of the lungs. There is no point in ventilating a lung if there's no blood going to it. As such, optimizing cardiac output and reducing pulmonary vascular resistance are important. Now, this is especially important in conditions such as in ventilation modes such as APRV, where actually you're increasing the intrathoracic pressure for a longer period of time during the respiratory cycle. And the patients are seeing much higher pressures than you would do with conventional ventilation throughout that respiratory cycle. Now, this can impair right ventricular filling and therefore reduce cardiac output. And therefore, even if you've improved the amount of alveoli that are opened up, if you've reduced the blood flow to the lungs, all of that good work from opening up the alveoli would have been offset by the fact that the lungs just aren't getting enough blood to them. So the patient may become progressively more hypoxic when you start someone on APRV inappropriately. The alveolar blood interface is really the problem and the reason why patients develop hypoxia and require positive pressure ventilation. This is usually related to getting an infection, inflammation, or pulmonary edema if, for example, they develop acute left ventricular failure. This will only improve with time, with chest physio, and with appropriate treatment, be that diuretics for pulmonary edema or antibiotics for bacterial infections. So what we're trying to do with all these advanced modes of ventilation is buy time to allow those treatments to start working. It's also worth considering carbon dioxide removal. Now, for most people with spontaneous breathing, what you're getting is the normal breathing in and out, the tidal volumes, and this is what removes the carbon dioxide, the so-called bulk flow of gases. So it's dependent upon the minute ventilation, which is a function of tidal volume and the respiratory rate. Again, as with oxygenation, it's so important to think about alveolar perfusion. Again, no point in having alveolar units, having gas coming in and out of it, if there's no blood to take the oxygen in and to remove the carbon dioxide as it's flowing past the alveolus. With APRV, you've also got a second mode of CO2 removal, the so-called diffusion excretion of CO2. If you imagine a continuous column of gas, if you've got a high concentration of carbon dioxide on one end and no carbon dioxide on the other end, you will slowly get diffusion of that carbon dioxide across. And so by keeping all the alveolar units open throughout the respiratory cycle, you can also help with CO2 removal. So paradoxically, you can actually make CO2 removal better with ventilation modes such as APRV, with even lower respiratory rates, effective respiratory rates, than with conventional ventilation. So it's again something worth thinking about, especially if a patient's got a disease process where lots of lung units or alveolar units are collapsed down. If you can maximize the amount of epithelial space and surface area that's undergoing gas exchange, you can improve CO2 removal through this as well. So the way to think about APRV is that it's essentially extreme CPAP. And that is what the PHigh is talking about. It is the pressure at which you're trying to maintain the lungs at for the majority of the respiratory cycle. The patient can breathe on top of this PHigh or the pressure high level, and this allows the patient to then excrete CO2, but what you're trying to do is to maximize the number of alveolar units that are open throughout the patient's cycle. It's also important to think a little bit about lung compliance. Now, when you see some of the values that we set as our PHigh or pressure high value, you may be surprised that they're quite high, 15, 20, 30 centimeters of water. And you might be thinking, gosh, how can a patient breathe on that? But this is where the concept of lung compliance comes in. With a normal lung, it's very compliant, it's very stretchy. However, as you get infection or pulmonary edema, what happens is that the tissues become sodden with liquid, be that water being extruded out in pulmonary edema or inflammatory exudates and pus in conditions such as pneumonias. And what that does is it reduces the compliance of the lung. Rather than it being stretchy, it becomes thick, sodden, and heavy. And therefore, it takes a lot more change in pressure to actually make a change in volume. And that's what compliance is. It is a measure of the change in pressure that you need to give a given certain change in volume of the lung. So it's worth looking at this graph here. Now, if you look at just the solid blue line, the inflation limb, what you can see is that at small lung volumes, what you're getting is you need a big change in pressure to get a smaller change in the lung volume. You know intuitively that that's right. Imagine blowing up a balloon. The first few puffs of that balloon, it's really difficult to get the balloon to actually expand up at all. And then, once it starts to expand, it becomes easier and easier. This is that point at the lower inflection point where it suddenly becomes easier to blow up the balloon. And then as you continue to blow up that balloon, you get to a point called the upper inflection point where it's kind of almost full to bursting. And then even though you're putting in extra pressure, extra breaths to try and get that balloon to expand up more, it becomes harder and harder till it pops. And that's exactly analogous to the lung. Now, when you've got an infection or you've got a diseased lung, what happens is, imagine that same balloon, but instead of it being a thin rubber balloon, now it's a thick rubber balloon. So you need even more pressure before you start getting to that lower inflection point where it becomes easy to inflate. And that's what you can do with PEEP. If you set just a general PEEP or positive end expiratory pressure of 5 on this uncompliant lung, it still takes a lot of pressure to get a small change in volume at PEEP of 5. PEEP of 10, still, you're below that inflection point, so it's still taking a fair amount of change in pressure to get a small change in volume. And then, when you've hit that PEEP of 15, suddenly you're in the middle of that inflection limb, and this is the bit where it's most efficient to breathe. Now you see this in APRV. You can see patients, they look like they're hyper expanded, their lungs are expanded up and they're breathing away on top, and it can look like they're being quite uncomfortable on that. But actually, these patients find this a lot more comfortable than PEEPs of 10 or 5, where they're having to generate bigger changes in pressure to get a breath in. And so this is why you shouldn't particularly be worried about having these big, high pressure, high levels. Because the reality is you need to treat the patient in front of you, and it depends entirely upon the compliance of their lung. If their lung's very uncompliant, there's a lot of disease, which is usually the case in patients being put on APRV, they may well need that higher positive end expiratory pressure or PHigh to just keep the lungs at a point where they're the most compliant for them. Now, with APRV, ideally what you would like to have is just a continuous high pressure to keep the lungs open, and then the patient breathes on top of that. Inevitably, however, these are patients who are very unwell, often been unwell for a little while, and so they're tired and their respiratory mechanics may not be as good, and they may well be weak as well. And for all of those reasons, just them spontaneously breathing isn't usually enough to clear the CO2 through bulk movement. And so that's why you need these small releases every so often, where you suddenly release the pressure in the lungs just drop down a little bit, and you get a bulk movement of gas coming out of the lungs and into the ventilator, which clears the CO2 and helps with CO2 management. So, in this talk, we're thinking about how we set the PHigh, the pressure high. When we have a patient in front of us, we're setting them up on APRV. How do we know what settings to set them on? Well, the next 4 talks are going to be going through each of the different 4 settings that we're going to have. However, the first of those is the PHigh. This is the high pressure that we're going to keep. This is the extreme CPAP equivalent PEEP. Now, the first thing to do is to put them on a volume control mode of ventilation. You can do this on pressure control, but I'm purely going to talk about volume control here, just because I think it's easier when you're first starting as on intensive care to look at volume. You look at the patient's ideal body weight, and then you calculate their ideal tidal volume. The ideal tidal volume is generally taken to be 6 mils per kilo. So for an 80 kilo patient, that will be 480 mils. Where this comes from is a lot of work looking at acute respiratory distress syndrome and looking at severe respiratory diseases where so-called lung protective volumes, which are slightly lower tidal volumes than we used to give. So if it's an 80 kilo patient, set it at 480. 6 times 80 is 480. And then let the patient have a couple of breaths on volume control mode. And see what happens. And then what you're going to have is a pressure waveform that looks a little something like this graph. You're going to have the pressure slowly increasing up and up and up until you hit the volume that you want. Then the pressures are going to equalize between the ventilator and the lung, which is the P plateau. And then you're going to release your breath as the patient exhales. Once you've done a few of these, you get an idea of how compliant the lung is. And if you look at this next picture, you can see that the patient is taking a breath in, and then you can do something called an inspiratory hold, where you press the button and you hold the inspiratory pressure. And you can see that the pressure goes up and up and up, and then it hits that peak inspiratory pressure, and then you've hit the volume that you need to achieve, and then the pressure just holds at that level, and then you get what we call the plateau pressure. Now it is the plateau pressure, or this sort of leveling off of the pressure that you get below the level of the peak pressure, which you can see in this ventilator screen. The peak pressure is 52, but the plateau pressure is 31. It is the plateau pressure that you want to use as your PHigh in APRV. It's as simple as that. Do an inspiratory hold, see what the plateau pressure is. You can see that value in the top right-hand corner of the screen, where it says P plat. That is the value that you want to use as your starting PHigh pressure. This slide just shows you all the different options that can be used with APRV and all the different things that can be set. So when we're talking about the PHigh, generally speaking, when we start a patient on APRV, we're looking at PHighs of between 25 and 30. That's because these patients often have quite severe respiratory disease, non-compliant lung, and therefore need slightly higher pressures to recruit up diseased consolidated lung. It's worth thinking a little bit about what happens once you've established a patient. So you've put them on a PHigh of 30. They've had a couple of days, the infection is starting to improve, they're having regular chest physio, suctioning up all those secretions, and the infection is improving with the antibiotics that you've given them. And so as the antibiotics are given, the compliance is also going to improve. So then oxygenation will also improve as well. So what you find is that your PO2s start to improve. Now the first thing to do when your PO2s are improving is to drop down your FiO2. Fractional inspired concentration of oxygen above 60% is known to be damaging to the lungs. In fact, probably any high amount of oxygen is bad for the lungs, but definitely above 60% gives a huge oxidative stress to the lungs. So the first priority is really to try and drop down the FiO2 to below 50% ideally, but between 60 and 50%. At that point, you want to try and see what lung compliance is. And you can do this in one of two ways. The most common way is the so-called drop and stretch. What this means is that you slowly drop down the amount of the PHigh by 1 to 2 centimeters of water every 4 to 6 hours. You must wait a period of time before making any changes to a ventilator on APRV. APRV is a slow mode of ventilation. You will not see changes within the first half an hour or even hour. And sometimes people make a change on APRV, come back an hour later, look at the blood gas and say, oh gosh, things are worse, and then change things again. You need to leave at least 4 to 6 hours for the changes to actually take effect. So don't rush with APRV. And like I say, what most people do is drop down the PHigh by 1 or 2 centimeters of water every so often. You can do it that way, or the alternative way is that you can switch it back to a volume mode of ventilation and reassess the plateau pressure and then see what their plateau pressure is for their ideal tidal volume of 6 mils per kilo. I'd caution slightly doing switching between volume and APRV modes of ventilation, because all that recruitment that you've achieved with APRV can be lost by just switching between ventilator modes every so often. So what I would advocate for is dropping down your PHigh slowly. And once you've got down to a PHigh of around 10 15 centimeters of water, you can then think about changing them over to a spontaneous mode of ventilation like CPAP pressure support. So it's important to always see what their lung compliance is, and therefore set a 6 ml per kilo tidal volume on volume control, work out what their plateau pressure is, and then use that as a starting point for setting your PHigh. Now, I really do warn you, and it's worth thinking about this. If you imagine suddenly increasing your intrathoracic pressure to, say, 30 centimeters of water for 5 seconds, you can quite severely affect the venous return to the right side of the heart. And so you can get patients becoming quite hemodynamically unstable, hypotensive, and therefore secondarily hypoxic as well because of a reduction in lung perfusion. So sometimes it's actually worth starting off with a slightly lower pressure of 20 or 25 centimeters of water and slowly working your way up, allowing the patient's body time to acclimatize to the increased pulmonary vascular resistance and reduction in venous return. And certainly I have seen patients become very unstable when novices have just turned straight onto APRV from a conventional mode of ventilation. Also, if you've got patients with a collapsed lobes or even one collapsed lung, what happens with APRV is that you increase the pressure, but if one side is collapsed due to sputum plugging and isn't seeing any of that increased pressure, all of it is going on to the opposite good lung, what you can do is increase the pressure on one side of the lung, the good lung, and so all of the blood then rushes into the side that's collapsed down, which has got a lower pressure, because blood is silly, it's not clever, it'll just go the path of least resistance. So if the right side of the chest has a peak pressure of 30, and the left side of the chest, because it's plugged up with lots of sputum, has a -5 or 0 pressure on that side, of course all of the blood is going to suddenly start rushing over towards the side that's not got the high intrathoracic pressure. So sometimes when you see patients with collapsed lung, you put them onto APRV, they can desaturate very quickly because you've shunted all the blood into the lung that's collapsed up. So again, if you're looking after patients who have large collapsed areas of lung or even one complete lung that's collapsed, be careful about how you start them on APRV, or if APRV is actually the right option at all for those patients. Because actually what you want to try and do is to maximize the amount of blood flow into the ventilatable lung. And so conventional modes of ventilation might be better. We talk a little bit more about this in the advanced ventilation talks later in this series. So that's PHigh. In a nutshell, what you want to do is look at the plateau pressure and volume control as set for a 6 ml per kilo tidal volume and set that as your PHigh. And then you work your way up and down depending upon the patient's hemodynamic stability and also their oxygenation as the situation improves. Thank you very much. If you've liked this video, please like and subscribe to the video and hit the bell notification because you'll see there's lots of videos coming out over the following months. See you for the next video.